There is a widespread assumption that reaching your late 30s with a stable emotional baseline means you are too old to suddenly develop unexplainable depression. The medical reality paints a very different picture. The years leading up to menopause actually represent one of the highest risk windows for severe mood changes in a woman's entire lifespan. Consider a composite fictional example we will call Sarah. She is in her early 40s. Without warning, she develops new-onset anxiety, severe cognitive brain fog, and flashes of irritability completely out of proportion to events in her daily life. Because women like our fictional Sarah are completely blindsided by these intense symptoms, they look inward for an explanation. They internalize this biological shift as a personal failure or a flaw in their character. Why does society and even the patients themselves constantly dismiss these severe psychiatric symptoms? People instinctively reach for the nearest logical explanation. They blame the exhaustion on work burnout. They attribute the anxiety to the stress of parenting, or they write off the brain fog as a normal part of getting older. This misdirection has a heavy cost. Women spend years actively trying to fix the wrong problems, exhausting themselves trying to manage external stressors, and ultimately concluding that their character is broken. To find the actual cause, we have to look at this lifespan timeline mapping a woman's age. Notice this prolonged blind spot spanning the late 30s to the late 40s. This biological timeline operates entirely beneath the surface, well before physical menopause actually occurs. The true crisis is a complete lack of medical and societal awareness. This high-risk transition is already well underway long before any traditional physical signs appear. We are looking at two parallel timelines. Up top, psychiatric signs like anxiety and low mood begin early. Down below, physical symptoms start significantly later. Medical providers typically wait for these physical signs, like hot flashes, to spike before discussing menopause. That massive gap between the early mood changes and the later physical signs is called perimenopause. It is a hidden transition period that can easily last for years. It is widely misunderstood as a gentle, manageable, and steady decline of hormones over time. Because those classic physical markers are entirely absent in the early stages, the severe psychiatric warning signs are routinely ignored by the medical establishment. Most assume estrogen levels follow a smooth, gently declining baseline. Instead, the true biological mechanism is a highly volatile, jagged line. These erratic fluctuations destabilize the brain, acting as a direct trigger for disproportionate irritability and new, unmanageable anxiety. Simultaneously, these hormonal shifts fracture a person's sleep architecture. This creates a profound, hollow exhaustion that standard rest simply cannot fix. This unyielding sleep loss then compounds the cognitive distress. It actively exacerbates the lack of focus, often described as brain fog, and pulls the low mood down even further. Certain populations face an elevated risk for this severe cascade. Women with a history of premenstrual dysphoric disorder, postpartum depression, or prior depressive episodes are especially vulnerable. Perimenopausal depression is a compounding biological chain reaction. It is a clear, trackable medical event, not a failure of stress management. Recognizing this transition as a physiological event provides immense relief. It requires targeted care, and it entirely absolves anyone of the myth that they are dealing with a personal character flaw. Stabilizing the mood requires specific, evidence-based behavioral treatments. Cognitive behavioral therapy, interpersonal therapy, and targeted sleep interventions are primary tools to manage the psychological fallout. On the medical side of the matrix, pharmacological options are highly viable. These interventions must be strictly coordinated with a medical provider who understands the specific neurochemistry of perimenopause. Keep in mind that treatment is highly individualized, and outcomes will vary from person to person. Only a licensed clinician can provide a diagnosis, and specific guidance regarding hormone therapy must happen inside a doctor's office. Navigating this requires a collaborative, two-pronged approach. It demands active, ongoing communication between specialized therapists and medical doctors. For the behavioral half of that care matrix, Coping and Healing Counseling, or CHC, provides a specific, accessible solution for residents of Georgia. They maintain a diverse, culturally competent team of over 15 licensed therapists, including clinical social workers, professional counselors, and marriage and family therapists. All sessions operate entirely through HIPAA-compliant telehealth. This telehealth model ensures total geographical access. As this map shows, CHC covers all 159 counties in the state of Georgia through secure video. Financially, they remove traditional barriers to care. Medicaid is accepted at a $0 copay, and most commercial plans like Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana range from $10 to $40 per session. With accessible, expert telehealth care available, women in Georgia no longer have to navigate the silent crisis of perimenopausal depression alone.